Good morning, ladies and gentlemen. I'm Akaradech P from Srinthorn Hospital. I would like to share the update treatment and surgical technique for trigonum syndrome. So the overview of the trigonum syndrome is an unfused secondary ossification center of posterolateral tubular tubercle, occur in about 2 to 50% of general population. It appears between 8 to 11 years old in the normal X-ray, about 2 to 7 of normal X-ray. The symptom is arise from repetitive use or injury lead to the sternal process fracture, synchondrosis disruption, or avulsion injury of the PTFFL. Patient mostly common in ballet dancer, swimmer, follower, footballer, whose activity most involved in forceful plantar flexion. The history have a pain in retrocalcaneal spread, especially when plantar flexion of the ankle with gradually onset. Patient may have a posterior ankle impingement test positive. We need to differentiate between acute trauma and chronic process. When the patient comes with a situation that has a hyperplantar flexion injury mechanism of the ankle, that we have a swelling and chymosis around the posterior ankle. It looks like it be a Shepherd fracture, synchondrosis disruption, or FHL rupture. But if patient comes with a gradual onset of pain on posterior ankle, we need to differentiate about scar tissue impingement, accessory muscle impingement, or osteochondral lesion of the talus. One condition is associated with trigonum is FHL tendonitis. Patient may report discomfort on the great toe as well as a posteromedial ankle. Some presented with the stiffness of first MTP joint in the dorsiflexion, mimic the situation of the hallux rigidus condition. The imaging plain radiograph can be shown the trigonum on the between posterior malleolus and superior aspect of calcaneus. In full plantar flexion, we show the impingement of trigonum impinge against the posterior malleolus. CT scan also used when trying to assess in case of suspected the fracture of trigonum. MRI we show the bone marrow edema, fracture line, fluid in synchondrosis, and also evaluate associated FHL pathology. So we start with the conservative treatment first. Normally we advise the patient to rest to limit hyperfraction activity of the ankle. Some patients need casting or NSAID medication. If all of these were introduced to the patient and it's not good, diagnosis lidocaine injection is suggested into the posterior aspect of the ankle to temporarily relieve and for the diagnosed aspect. So the local steroid injection can be used under fluoroscopy or ultrasound and can relieve symptoms and predict outcome after excisional surgery. But steroid injection should be avoided in the blind technique because of it increased risk of Achilles tendon rupture or other tendon rupture if intratendinous injection was made. Overall success rate above conservative treatment is about 60 to 80% after 4 to 6 months. After fully conservative treatment, but clinical not improved is indicated for the surgery. The surgical option is divided into the open traditional approach and arthroscopic or endoscopic approach. I will talk about open traditional approach first. When you do the open, you can do as a supine position with the medial approach via the FHL tendon sheath and neurovascular, or via the lateral approach between the peroneal tendon and sural nerve, or PL approach between Achilles tendon and peroneal tendon. But most common use is in the posteromedial approach when you use an open. We identify the flexor retinaculum longitudinally inside over the neurovascular bundle and retract it, exposing the FHL tendon and sheath, recess inside the sheath of FHL and identify the trigonum and remove it easily. The outcome is good, satisfactory pain relief, return to dance okay, low complication rate. Both PL and PM approach is good also, but the PL approach is usually recommend only excision of trigonum and PL process because of it's directly to the bone and no major neurovascular structure in the area except of a small sural nerve. However, the PM approach is better when there is a bony impingement accompanied with the pathology in the FHL tendon or neurovascular bundle. In the study with the RCT 5-year follow-up published in AOSSM 2017, they compare open and endoscopic approach in all athletes. 52 patients, 26 open, 26 endoscopy. They found that endoscopy had a significant improvement of alpha high foot score comparing to the open, but there no significant difference between post-op WAS score. Endoscopy has a better time to return to training, less time to return to previous sport level, and overall complication rate is less than open. So, endoscopic excision of the osteoconum is a very safe and effective treatment option for athletes who require early return to previous sport level. Let's do the endoscopy. Start with the patient position. In the prone position is most common. Ankle placed over the edge of the table with the FC lateral pelvic support. The portal. The portal, we start with the PL portal first. The landmark is the tip of the lateral malleolus. Draw the parallel line with the sole and draw straight to the Achilles tendon. PL is located about 5 mm anterior to Achilles tendon. PM also located at the same level of the PL. When we apply the PL approach, we need to know something that structure is called structure at risk. In the PL is sural nerve and lesser saphenous vein. The portal to nerve distance is farther or safer when you perform in the plantar-flex position more than dorsiflex position. For the PM approach, structure at risk is the tibial nerve and posterior tibial artery. Portal to nerve distance is also safer when you do in the plantar-flexion. So in the prone position, slightly plantar-flexion is very safe for the application of the scope in the posterior. PL approach, PL portal, we apply the 4 mm arthroscope. PM, we apply the shaver in about 30-degree arthroscope during the posterior arthroscopic operation. When we apply the scope, we need to know the anatomical landmarks surrounding the osteoconum. The first one is PTFL is attached in the medial side of the osteoconum or of the posterior lateral talar process. The second one is FHL is in the medial side of the osteoconum or posterior lateral talar process. And the other things is need to know this number 6 is medial talar process and intermalleolar ligament is above that. So look for the case. This case is female 24 years old complaining progressive PL ankle pain, mild swelling, tender and deep peroneal, deep posterolateral aspect of the ankle. Posterior ankle impingement positive. And the left side, the normal X-ray, we found that there's small osteoconum around here, above the calcaneus and below the posterior malleolus. From the MRI, there is fluid surrounding the osteoconum. This case failed conservative treatment. We process with the surgery. The PL portal parallel to the plantar line, lateral to Achilles tendon, and PM is the same level. We create an incision, mini skin incision about 7 mm both sides, and use the hemostat clamp to create a free space by PL aiming to the second toe, PM aiming to the tip of the fibula. After we create space, already we apply the 4.0 mm arthroscope, endoscope inside. First, we found the fatty tissue around the high foot posterior ankle. We debride it to identify the osteoconum and identify the FHL tendon first. We use the FHL as an important boundary for protection of neurovascular bundle on the medial. All soft tissue circumference of osteoconum are debride, including the retinaculum of FHL medially, PTFL laterally, and after that we use an osteotome to resect the synchondrosis, create a free movement of the osteoconum. If the osteoconum is quite small, not too large, we can use the clamp and remove it in one piece with the rotating like a crocodile roll. But if the osteoconum is quite large, we can grasping it or burr it into the small piece and remove it. This one is it can remove easily with the crocodile roll in one piece from the posteromedial portal. After we remove it, we're looking for the associated conditions such as FHL tenosynovitis, FHL tenosynovitis, or FHL tendon tear. We debride it, soft tissue around the FHL tendon, check the gliding, flexion and extension, the big toe, and see whether there are remaining impingement or not. If there's something impinged in the subtalar joint, we debride it, we clear it with shaver and electrocauterization. So, the post-operative film, osteoculum is gone. Clinical is good. Recent midterm outcome of the endoscopy study from Tanaka group and from Japan, they found that 72 posterior arthroscope follow-up about 5 years. The cause is mostly occur with the osteoculum. The alpha score with improved from 79 to 97%, 97 pre and post-op. Average time to training is about 5 weeks, and time to return to competition is 13 weeks. In some group of the doctor from Korea, Woo Chun Lee, he proposed the arthroscopic excision of symptomatic osteoculum in lateral decubitus position. He used a subtalar arthroscopy with a 2.7 millimeter with the AL and CL and PL portal to debride the inflamed tissue around the subtalar joint and from the centrolateral to identify the synchondrosis and detach the osteoculum with a dye shaver and curettage and remove the osteoculum from the posterolateral portal. The report a good outcome after that, and mean time to resumption to the sport activity is about 6 weeks. The other group in Korea comparing arthroscopy, subtalar arthroscopy with the posterior endoscopy in retrospective cohort study. They found that both arthroscopy and endoscopy were safe and effective in treatment of the posterior ankle impingement syndrome. But the subtalar arthroscopy is more demanding, especially when the size of osteoculum is too large. It's difficult to remove it via subtalar arthroscope. The posterior endoscope is a hard advantage in addressing problem in posterior ankle joint and allow more extensive release of HFL tendon. Muffley in 2020 proposed the new technique in the treatment of posterior ankle impingement syndrome by two posteromedial portal. He suggests to use the two posteromedial portal instead of posterolateral and posteromedial portal because of they can be do in the supine position with the figure of 4 position. First portal is distal, medial, anterior to the Achilles, parallel to the calcaneal tuberosity from tip of medial malleolus. The second portal is about 5 cm proximal to the first, and they report a good functional outcome score and time to return sport at about 8 weeks with no complication rate. So our preferred post-op protocol is about first and to second week. Patient has allowed to the full weight bearing on the cam boot, FHL ankle dorsiflex, plantarflex range of motion exercise can be done. After third week, we try to wean off the boot and return to normal shoe and start the muscle strengthening exercise around ankle and FHL strengthening exercise. About 8 weeks post-operative, patient is allowed to return to sport. Overall complication rate in the posterior ankle scope with osteoculum resection is about 8% in 13 literature, mainly in the perioperative complications such as pseudo-neuropraxia, CRPS, superficial infection. But the one complication that can be prevented and very important is a painful stress reaction in the posterior subtalar joint after resection of osteoculum. They proposed in the International Orthopedic in 2017 with the 30 feet was average. The resection of the osteoconum or posterior talar process had a complication rate with a painful stress reaction about 13% of the patient fall in 30 feet, and all have a painful stress reaction, maybe can be a career ending in athlete. All patients show the talar edema due to high joint pressure caused by reduced joint surface after resection. They clarify the risk configuration. This called the radius of talus ending within the subtalar joint. Looking for this picture, the radius of the talus, if it ending into the subtalar joint, the trigonal process, when we resect it, the length of uncovered calcaneal joint surface is longer than the normal feet. So the pressure is increased a lot after resection. Length of uncovered calcaneal joint surface significantly larger in feet with permanent damage than the normal feet. So they suggest that resection should not be made anterior into the subtalar joint in case of radius of the talus ending within the subtalar joint to prevent the stress reaction. The other thing that need to know that PTFL integrity, because it attached with the osteoconum and posterior talar tubercle. A study from Chiang Mai, Jantanwat Wasinon, study with the cadaver have a 4 level of bony excision of the posterior talus. They found that if the PL tubercle excision stay up to the bottom line of the FHL groove, in the picture B, at least 89% of PTFL can be preserved and integrity it remain. So don't cut beyond the bottom line of the FHL groove. So I would like to share the some case of a rare condition of posterior ankle impingement. You will see that the foot lateral, there's a small tiny trigonal process and sclerotic bone on the posterior limb of the malleolus of the distal tibia. When we send to the CT scan, we found that there's some sclerotic bone around here, the focal lucent nidus with surrounding sclerotic reactive bone. MRI is sensitive, it's non-specific, and often can be identified nidus, but in this case can be shown that nidus is around here. Hyperemia and bone marrow edema is around here. So this rare condition is osteoma of the posterior malleolus. We apply the posterior endoscope, resect the excess trigonal process, and identify the unhealthy tissue on the posterolateral of the distal tibia, and use a burr to remove it. You will find that the tissue is pinkish and unhealthy around here. We debride until the bone is yellowish already. Okay, take home message. Both open and endoscopic approach give a favorable outcome. Endoscopy have a better time to return to sport and training, less complication, and recently show good midterm outcome. Arthroscopy is more demanding and can well detect FHL associated problem, vice versa the endoscopy. PL tubercle resection should not be on the bottom line of the FHL group to preserving the PTFL footprint. And to prevent the painful stress reaction over the posterior subtalar joint, the resection should not enter anteriorly into the subtalar joint. Thank you.